Hey everybody, welcome back to the ECG of the day. My name is Reid, and before we get started, don't forget to download the PDF of this ECG down for the description below, and to like and subscribe to the channel if you enjoy the content. So let's jump into it. So let's take a look here at lead 2. We'll look at the forest, and so kind of just getting an idea of what is going on with our QRSs. Seems like we've got a wide QRS rhythm that has maybe this early beat, and then we get that wide complex that stays the same throughout the entirety of the strip. And usually when you see a wide rhythm, right, you wonder, is this a ventricular rhythm, right? Because we know that wide means that it's going aberrantly slowly through gap junctions throughout the QRS complex. But when you see an early beat like this that looks the exact same as the normal QRSs, it makes me think that these QRSs are aberrantly conducted from somewhere within the atria, because early beats don't really happen in the same morphology unless they're still taking that same His-Purkinje type of aberrant conduction through the QRS. So when I look in front of each QRS, I do notice P waves, right? I see some P waves here. And if we evaluate the atrial activity, we can see those P waves are upright in lead 1. They are upright in AVF, so they are sinus P waves, right? And those sinus P waves are occurring at a rate of roughly, if I start maybe here and count backwards, we've got 300, 150, 100, 75, 60, and that would be 50, so somewhere between 60 and 50, maybe 55 beats per minute. So we've got a sinus bradycardia, okay, with this one early beat that has a little bit of a pause after. So we'll kind of go through that later. Let's take a look at what the AV node's doing. You know, our AV node is our PR interval. It's the next thing that should be occurring after sinus P waves come down and get captured by the AV node and delayed by 120 to 200 milliseconds. And so my PR interval here looks to be in between 120 to 200 milliseconds. And so it's a normal PR interval. And so now it's my job to make sure that all of these P waves are conducting to QRS complexes in the same fashion, right? Here's our early beat. We'll look at that in a little bit. But all the P waves conduct to QRSs. And I don't see any extra P waves so far outside of maybe our funky beat that occurred earlier. We'll look at that in a little bit. But no extra P waves throughout any of these. So that's reassuring. Now, the next thing we're going to do is we're going to evaluate this wide complex QRS, right? And so our QRS, if we measure the interval, my QRS duration is just greater than 120 milliseconds, right? It's maybe 130, 140 milliseconds, so it's wide. It tells me that there's likely, if it's coming from the AV node, which I think it is, then when it's going down that right and left bundle branch blocks, fascicles, there's some type of conduction disturbance, right? And so I look for bundle branch blocks and things like that, and what I see is we've got this kind of R prime signal. We've got a little R prime, right? You can kind of see like a little RSR prime in a way. So we get this R prime, and so I think that's enough evidence to tell us that we've at least got a block of the right bundle branch. You can see it really good here in V2, this big R prime, right? Big R prime here in V2. So we've got a right bundle branch block. But our QRS axis is upright in lead 1, but negative in AVF, and it's negative in lead 2 as well, which tells me that my QRS axis is like way up and to the left axis deviation. All right, we've got a left axis deviation. And I know that in the setting of right bundle branch block, oftentimes left anterior fascicular blocks cause that. And so you can see here, we've got this little Q big R pattern in lead 1, and we've got this little R deep S pattern in lead 3, and so that little R S pattern in that lead have got some left axis deviation. Maybe we have a left anterior fascicular block, and on top of that, I would say we've also got criteria. You know, left axis deviation isn't just all left anterior fascicular blocks. Sometimes you can have some minimal kind of criteria for left ventricular hypertrophy, which could also deviate the axis to the left. And if you look in AVL, we know that if AVL is greater than 11 millimeters, there might be left ventricular hypertrophy. if that R wave is greater than 11 millimeters, I'll say. And so if we see we've got from there to there, we've got 5, 10, 13 millimeters. And so we have some criteria here that might make us think left ventricular hypertrophy. Okay. So maybe some LVH, maybe an anterior fascicular block as well. Alrighty. And now, the last thing we're going to do is we're going to take a look at that QT interval. And if you look in between two R to R's, and if I find the midway point, notice my T wave ends by that point, so that's reassuring. Because there's the repolarization, which is our QT interval, is correlated to the rate, so you can use the R to R intervals. I look for any pathological Q waves and ST and T wave changes. I don't see any active ST T wave changes that makes me think of ischemia. Pathological Q waves, maybe we have some Q waves in the septum. It's really hard to say, right? So it would make sense if we did have a prior septal infarct that maybe we kind of hit, the anterior fascicle and the right bundle branch. It's hard to say, right? So maybe in the setting of all these conduction disturbances, I would probably just correlate this to a previous ECG and see if this is something that's been consistent throughout. So the last thing we're going to do is we're going to take a look at this early beat, right? The early beat has a QRS morphology that is the same. And so we know that in that case, it's either a premature atrial contraction or a premature junctional contraction, because both would arise, at least the ventricular depolarization would be following the same path as the normal QRS complex. And so now, the best way to discern between the two of those is to look in front of my QRS, and I look on top of the T wave of the previous beat, and in fact, I could look here in V1, and I don't see any P waves. So this can't be a premature atrial contraction. In fact, it's a premature junctional contraction. What's really interesting about the junctional contraction here, right, is that just after the junctional contraction, if you look up here in V1, just after the premature junctional contraction, we actually have, right after it, a sinus P wave. So if you notice that P wave, that is that sinus P wave, is actually occurring kind of on time. We just have a PJC that occurred right before, right? So we have, look, sinus. The next sinus beat would be right there, but we happen to have this PJC that occurred right before it, and so because of that, our sinus P wave is blocked, right? It doesn't conduct to the QRS. Why? Well, because our premature junctional contraction that sent signal down to the ventricles created a scenario where the next sinus beat that came down was functionally blocked at the AV node, right? So that's what occurs there, and then we have the resumption of our normal conduction throughout the rest of the rhythm. So when you put this all together, what do you get? You have a sinus bradycardia at a rate of roughly 55 beats per minute. You've got a right bundle branch block and left anterior fascicular block. If you would like, you can call that a bifascicular block. With left axis deviation, that might also be explained by some electrical criteria for left ventricular hypertrophy as well, drawing that signal even more to the left. And then we've also got evidence of a premature junctional contraction that causes a sinus P wave to be blocked. So I hope this helps you kind of understand some of the physiology in these rhythms, and if you have any questions, feel free to reach out. You can comment, you can send me an email. I have my email is on the homepage, so feel free to subscribe to the channel if you like these videos, and I hope you do. I enjoy making them, and yeah, hope you have a great rest of your day, and we'll see you on the next ECG video.